Hi everybody, Dr. Mike here. Did you know your heart beats around about 5,000 times in an hour? Which means it beats around about 3.5 billion times in your lifetime. Now, in order for a heart to beat, it must contract, and in order for a heart to contract, it needs electrical stimulus telling it to contract. So this video is talking about that electrical stimulus, what we term the neural conduction of the heart. Now what I've drawn up here is a heart, and you can see the 4 chambers of the heart, the 2 atria at the top and the 2 ventricles down the bottom. We've got right atrium, right ventricle, left ventricle, and the rest, all this tissue here, is heart muscle, and we term that myocardium. That's what contracts. When it contracts, it squeezes blood through these particular chambers into the various veins or arteries. All right, now when a heart contracts, did you know that your heart can spontaneously contract it? I could take a heart out of your chest and it could beat by itself. Now the reason why your heart can beat by itself is because of a specialized set of myocardia right here, heart muscle, right there, and what these specialized group of neuron myocardium-like tissue does is it spontaneously fires off. It spontaneously sends a signal. In actual fact, every around about 60 to 100 times per minute, it will send an electrical signal. And it begins here at the atrium. Now, because it sets the rhythm of the heart, that's what we term the sinus rhythm. And because this group of specialized cells sit at the atria, it is termed the sino-atrial node. Also just termed the SA node. So the SA node starts the rhythm of the heart that we term the sinus rhythm. It does it around about 60 to 100 times a minute, and it can do it by itself. Now the brain can impact how fast or slow this beats through a specialized part of the nervous system called the autonomic nervous system. That's the sympathetic or parasympathetic, fight or flight, rest and digest. But we're talking about just the sinus rhythm now. When it sends that electrical signal, it actually sends it through the myocardium of the atria. And it does it in that fashion, sends it out through the myocardium. Now another important point is when an electrical signal is sent through muscle, in order for that muscle to contract, calcium must jump into the cells. So the order is electrical signal, calcium jumping in, muscle contracts. So that sent the signal, calcium's going to jump in, those atria contract, pushes blood down into the ventricles. That's initiated by the sinoatrial node. Now the next thing is we've got this bit of tissue right here. This tissue stops the electrical signal. It stops the electrical signal and funnels it to one particular point right here, another node, another group of specialized cells which sit between the atria and the ventricles, and therefore it's called the atrioventricular node. Atrioventricular node, also just termed the AV node. Now, this is important. The electrical signal gets stopped at this bit of tissue right here, okay? And it stops for around about 0.4 of a second. So we've got the boom is going to be the next part. So this is that pause between the 2 beats of your heart. So it all funnels into the AV node, and then the AV node sends the electrical signal down this bundle of neurons that we call the bundle of His. Bundle of His. Now the bundle of His branches off into left and right bundle branches. Left and right bundle branches. And these left and right bundle branches go down this septum between the 2 ventricles that we call the interventricular septum. Now, as it moves down, it goes down to the apex of the heart and then up. And then you've got various branches going down like this. Okay, these are called Purkinje fibers. Again, Purkinje because it's named after some old dead white guy. But these are the Purkinje fibers. and they send the rest of the electrical activity into the myocardium of the ventricles. And again, calcium jumps in and they contract, pushing blood out of the heart. If it's the right side, it goes to the lungs. If it's the left, it goes to the body. So what do we have? What's the order of electrical conduction of the heart? SA node fires off around about 60 to 100 times a minute. It shoots through the myocardium of the atria. It gets stopped by this bit of tissue and funnels through the AV node. That's a break of around about 0.4 of a second. The AV node, if the SA node wasn't there, the AV node is also a set of pacemaker cells, and that fires off around about 40 to 60 times a minute. So a little bit less than the SA node. Then it funnels it down the bundle of his, down the left and right bundle branches, and then through the Purkinje fibers that send that signal to the myocardium of the ventricles, so calcium can jump in and those ventricles contract. So this is the neural conduction of the heart. Hi everybody, Dr. Mike here. In this video we're going to take a look at how the SA node, which is the sinoatrial node, and the AV node, which is the atrioventricular node, how they send their signal, their electrical signal that we term an action potential, to the rest of the muscle of the heart to tell it to contract. So what we need to go through is, firstly, if I were to draw the heart up itself, and just very quickly, I've got the heart here. We know that there's a fibrous bit of tissue here that separates the atria, the two chambers at the top, and the ventricles, the two chambers at the bottom. And we know that there is a specialized type of myocardium, which is heart muscle cell, a very specialized type that sits at the back of the right atrium that we term the SA node. Now, these cells spontaneously depolarize. What's that mean? It means they spontaneously send an electrical signal. They actually do this around about 70 to 100 times a minute. And when they send this signal, they spread the electrical signal to the surrounding heart muscle tissue in a fashion like that. Now, as it spreads that signal through what we term the myocardium, the heart muscle of the atria, that then tells the heart muscle to contract, and they squeeze and push the blood down into the ventricles. Now, the electrical signal wants to spread down into the ventricles, but it can't because of this fibrous bit of tissue here. But the electrical signal can bottleneck itself through another specialized group of myocardium that we now term the AV node, the atrioventricular node. And the action potentials are being pushed through this AV node, and therefore the heart muscle doesn't contract for 0.1 of a second. There's a break between the atrial contraction and the ventricular contraction of 0.1 of a second. This gives the heart enough time for the ventricles to fill with blood after the atria contract. Once that 0.1 of a second has occurred and the action potential spreads down the AV node, it goes down into what we call the bundle of his, and that spreads to the left and right bundle branches, and then they send electrical signals through the ventricular heart muscle, and as it spreads through, that action potential then tells the muscle to contract and blood gets squirted out. If it's the right ventricle, it goes to the lungs. If it's the left ventricle, it goes to the body. So what we're talking about is, today, the SA node and the AV node, how do they send their electrical signals? If I said the AV node spontaneously depolarize, they just basically stimulate this action potential all by itself. How does it do it? Well, let's first have a look here. Actually, let's have a look here at a cell of the SA node. So I said there's specialized myocardium, so it looks a little bit different here compared to normal myocardium, but it is connected. You can see there's a conversation that can be had between the SA node and the myocardium. Now, the first thing you need to be aware of is that all cells of the body have a very special pump called the sodium-potassium ATPase pump. Let's draw this sodium-potassium ATPase pump right here. And what it does is it uses ATP. We know ATP is the energy currency of the body. Uses ATP to throw 3 sodium out of the cell and throw 2 potassium into the cell. Now I want you to think about that. If we throw 3 positive sodium out of the cell and throw 2 potassium into the cell, where do we have a net positive charge? Well, we've got 3 positive things outside, 2 positive things inside. The net positive charge is outside, which means the net negative charge is inside. And if you were to compare those charge differences, what you would find is inside compared to outside is negative 5 millivolts, okay? So on this table here, where we've got 0 millivolts down to negative 90 millivolts up to positive 20, negative 5 millivolts is only around about here. Now, this isn't all that's happening. But what is happening due to this is we're accumulating a whole bunch of sodium outside the cell, and we're accumulating a whole bunch of potassium in the cell. That's the first thing. Second thing is this. This cell is quite leaky to to potassium, and if it's leaky to potassium, we're going to have potassium leak out of the cell very slowly. Now, if positive potassium is leaking out of the cell, it becomes even more negative inside, right? Because positive things are going out. So it goes from negative 5 actually all the way down to around about negative 55. And so we've now got around about negative 55, a charge difference inside compared to outside. So inside's negative 55 compared to the positive outside. Now another thing that's happening is this. These SA node cells are leaky not just to potassium, but they're also leaky to sodium and calcium. So what you'll find is this. You're going to have some cells here. Let's draw this as a square. You're going to have some channels here, that are leaky to calcium. And I want you to think about this. Calcium sits predominantly outside the cell. And it will leak into the cell, which brings a positive charge inside. In actual fact, there's also leaky sodium channels, which bring positive sodium into the cell as well. Now you're probably getting confused here. We're throwing 3 sodium out, 2 potassium in, but potassium is leaking out, making it negative inside, but we've also got calcium and sodium leaking inside, making it positive inside. It doesn't know what charge it is. In actual fact, what that means is this. Its baseline is around about negative 55, but because of the leaky calcium and sodium, it actually is always drifting up towards the positive, because all this calcium and sodium is slowly drifting in. Now, in actual fact, there is a mark right here at around about negative 40. Now, this mark at negative 40 is what we term the threshold, and it's the threshold for what? Another group of channels. What are these channels? They're another type of calcium channel. At negative 40, this is the key that unlocks this new type of calcium channel, a faster calcium channel. And when that opens up, more calcium rushes in. And when more calcium rushes in, what we get is a fast stimulus up to around about positive 20. Now, when it hits, as this is happening, going up to positive 20, what you'll find is that at around about positive 20, more potassium channels open up. Remember, these were just leaky potassium channels. Now we've got very specific potassium channels opening up, and heaps of potassium start to leak out of the cell. Now, if heaps of potassium leak out of the cell at positive 20, the positive is going back out again, and it drops back down to around about negative 55 to negative 60. Now, if it's dropping back down to here, what happens again? The whole thing occurs. Leaky calcium, leaky sodium, and then it goes back up to negative 40, which then opens the calcium channels, and that sends the signal back up, which closes the channels but opens the potassium channels, and it drops back down. So what do we have here? Basically, to summarize, we've got, at this point here, it's sodium and calcium leaking in. At this point, we've got calcium shooting in. And at this point, we've got potassium going out. Now, what we term this part is depolarization, this part is repolarization. Depolarization, repolarization, and this is what's happening at both the SA and AV node. And as you can see, it just spontaneously does this, and it does it at the SA node. It does it around about 60 to 100 times per minute. And at the AV node, it does it around about 40 to 60 times per minute. And this is what we term the pacemaker cells of the heart. So these are the action potentials of the SA node and AV node. Hi everyone, Dr. Mike here. In this video, we're going to talk about how the nervous system can control the heart rate and contraction. So, first thing we need to talk about is, we know the sympathetic and parasympathetic divisions of the autonomic, that's automatic, nervous system. You don't control this consciously, but the sympathetic nervous system is that fight or flight. It gets stimulated in times of stress or fear, and the parasympathetic nervous system is the rest and digest. It gets stimulated in times of digesting and relaxation. Because we know exactly what happens to our body in these scenarios, you should know which one causes an increase in heart rate and contractility, and which one causes a decrease in heart rate. Well, sympathetic, fight or flight. What happens when you're scared? Heart rate increases and the contractility or the force of the heart rate increases as well. Now, this is sympathetic innervation. Let's take a look. Sympathetic innervation is going to begin for the heart at the cardio-acceleratory center. It's a big name, but this is the part that controls the speed of the heart. It is here at the medulla. So remember your brainstem, right? Your brainstem has the midbrain pons medulla, and this is the cerebrum, the chunk of the brain. So midbrain pons medulla, lowest part of the brainstem is the medulla, and at the medulla you've got a specific area dedicated to increasing the speed of the heart called the cardio-acceleratory center, and we've got sympathetic nerve fibers present, as you can see here, and what they do is they send a signal down the spinal cord until it hits the thoracic 1, 2, 3, and 4 area. So your thoracic 1, 2, 3, 4, as you can see here, and shoots a signal out to what we term the paravertebral ganglia, okay? So for the sympathetic nervous system, there is a group of cell bodies that sits outside the spinal cord that we term the para, meaning next to, vertebral, so next to the vertebrae, ganglia, just meaning a group of cell bodies outside the central nervous system. And this is where the sympathetic nervous system synapses with their neurons, okay, with the next neuron. And you can see that happening here. First neuron shoots out T1 to T4 and then synapses with various cell bodies of the next sympathetic neuron here at the chain at the paravertebral ganglia. Now they go up and down, right? And they send their signals out going towards the heart. Like I said, this is a sympathetic nerve fiber or nerve fibers going to the heart. And where does it innervate? It innervates the SA node, it innervates the AV node, and it innervates the myocardium of the ventricles. So I'll say it again. The SA node sets the rhythm of the heart. It spontaneously sends signals between 70 to 100 times a minute. This is what sets the pace or rhythm of your heart. The AV node, if the SA node cramps itself, the AV node will kick in, and that spontaneously depolarizes around about 40 to 60 times a minute, so a little bit slower. So that's the reason why the SA node sets the rhythm, because it just does it faster than the AV node, okay? Now, the muscle, if you've got sympathetic nerves innervating the muscle, it's going to tell them to contract harder. So SA node and AV node, speed, musculature, contractile force. So the sympathetic nervous system, when it sends a signal down, it's going to release noradrenaline or norepinephrine if you're in the States. And this noradrenaline, what it's going to do is this. The noradrenaline will, so this is the cell of these nodal cells, right? SA node or AV node. And you know already that there's heaps of sodium outside the cell, there's heaps of calcium outside the cell, and there's heaps of potassium inside the cell. And if I were to measure the charge difference between outside and inside, we know inside is more negatively charged compared to outside. If you're unsure why, watch one of my previous videos. Inside is actually sitting at around about negative 55 millivolts compared to outside. And we know if we want these SA or AV nodes to send signals through the heart, they need to hit negative 40. That's the threshold. Now, to go from negative 55 to negative 40, that's going more positive. Negative 55 is more negative than negative 40, right? So to go from negative 55 to negative 40, positive things need to go into the cell. What are the positive things? Sodium and calcium. Now, if enough sodium and calcium go in, it hits negative 40, we've hit the threshold that opens up a whole bunch of more calcium channels, and huge amounts of calcium shoot in, making it really positive inside the cell. And now what we've done is we've sent an electrical signal through the SA node and the atria. Now, what do sympathetic neurons do? The sympathetic innervation, when it releases adrenaline or noradrenaline, it binds the specific receptors here that are called beta 1 receptors. Beta 1 receptors are located at the SA node, AV node, and the myocardium. And what they do is they let sodium and calcium in. allowing for this to happen more frequently. Hence, the heart rate increases. That's the sympathetic neuron. What about here at the myocardium? Is it doing the same thing? Well, myocardium, in order for it to contract, it only cares about calcium. So what happens here is it more specifically allows for more calcium in. Calcium into the cell, increased contractile force. So that's how the sympathetic neurons tell the heart to increase its contractile force. So sympathetic, increase heart rate, increase contractility. Beautiful. Now what about the parasympathetic, rest and digest? It slows the heart down. Now this is coming from, again, the medulla, but the dorsal aspect of the medulla, and this is the cardio-inhibitory center. And when the sympathetic neurons get activated, they can synapse with an interneuron. That's simply a neuron that's the intermediate between one and another, and that synapses with neurons of the parasympathetic nervous system, or more specifically, the vagus, in the dorsal or back aspect of the medulla. This then fires vagal nerves out. Now the vagus nerve is a cranial nerve, so it doesn't go down the spinal cord. The vagus nerve comes out of the head and neck, okay? And as you can see, it's shooting out, and what it does is it innervates the SA node and AV node, and rarely, or not many, fibers innervate the musculature, so I haven't drawn it in. So the main effect of the inhibitory signals from the parasympathetic neuron, specifically the branches of the vagus, is that it goes to the SA node and AV node and tells them to slow their signals down. I want you to think about this. How does, or how could it tell this nodal cell to slow its firing down? I told you to increase it, more positive things need to go in. So what do you think? To decrease it, again, remember, in order for it to send a signal, it needs to hit -40, so it needs to become positive inside. But to slow it down, to make it harder to send a signal, what you could do is send positive things out, right? And what do we have inside? Potassium. So what the parasympathetic fibers do, more specifically the vagus, when it innervates the SA node and AV node, it releases acetylcholine. So I said sympathetic released noradrenaline, the parasympathetic released acetylcholine, and that told potassium to leave the cell. This positive stuff is exiting, which means it goes from -55 even lower. Now when it goes even lower, the distance that it needs to then go from, let's just say -60 or -65 to -40 is far greater than -55 to -40, which means you need way more positive things coming in. It makes it harder to send a signal, harder for the heart to contract, harder for the heart rate to increase. So the way the parasympathetic nerve fibers do it, they release acetylcholine to the SA and AV node. It increases the efflux of potassium out of the cell, making it more polarized. That's called hyperpolarization, which means it makes it more difficult to depolarize and therefore slows the heart down. So this is how the central nervous system tells the heart to speed up or slow down. So in this video, we're going to have a look at ECG placement. Now, firstly, what does ECG stand for? It stands for electrocardiogram or electrocardiograph. And it's a way of measuring the electrical activity of the heart. Remember that the heart's a pump. It's a muscular pump that when it contracts, it will push blood either from the atria to the ventricles or from the ventricles out of the respective arteries. Now, before it can contract, electrical signals need to be sent down through this muscle tissue. And ECGs measure the direction that these waves move. Okay? Now, what we're going to look at today, or very quickly in this video, is what we call a 12-lead ECG. Okay? Now, please be aware that leads are different to electrodes. The electrodes are the sticky dots that you place on the patient. The leads are basically the set of eyes on the heart, having a look at what's going on, giving you the ECG readout, okay? So in a 12-lead ECG, we have 12 views of the heart, but in actual fact, we only use 10 electrodes to get these 12 views, okay? So what I'm going to do now is just show you exactly where these 10 electrodes go. And then in the next video, I'm going to have a look at how these electrodes view the heart differently. So, of the 10 electrodes, you are going to find that 4 of them go on your limbs. One on the left hand, one on the right hand, one on the left leg, one on the right leg. They're 4 electrodes. The other 6 of the 10 electrodes go on the chest, and they're called the precordial electrodes. And they are also the electrodes that give you the precordial leads or precordial readouts. So, first thing I want to do is draw up the chest. So what we're going to do is first of all draw the sternum. Just very simply. We're going to draw the sternum, we're going to draw the clavicle. We're going to draw some ribs, maybe 6 or so ribs. 1, 2, 3, 4, 5, 6. Okay. Now, when we place these, what we call precordial electrodes, we have 6. We start with the first one, and we call the first one V1. Now, where does V1 go? Remember, please remember that when you're looking at the patient, that's the right side, that's the left-hand side, and you know that the heart sits behind the sternum, a little bit to the left, turned a little bit, so the apex or the point of the heart is pointing towards the left hip. So you need to keep that in mind because that's important when it comes to the placement of these leads, of these electrodes. Okay, V1, first electrode, we place, find the sternum, go to the right of that sternum, and then count your ribs. Go to your 4th rib, and after that 4th rib is your 4th intercostal space. So that's 1, 2, 3, 4. So to the right of your sternum at the 4th intercostal space, 1, 2, 3, 4, we place the first electrode, V1. Now, V2 is very easy because it goes again at the 4th intercostal space, but on the left-hand side of the sternum. So that's where V2 sits. Now, usually you'll skip V3, and I'll show you why in a second, and move to V4. To find where V4 goes, you find the clavicle and go mid-clavicular, and you'll move down to the 5th intercostal space, okay? And that 5th intercostal space, if you feel, you should be able to feel your heartbeat. What you're actually feeling is the apex of your heart hitting the precardium, okay? That's the 5th intercostal space. And that's where you put V4. So mid-clavicular, 5th intercostal space, V4. V3 simply goes immediately between V2 and V4. And V5 and V6, very easily, go at the 5th intercostal space, but move towards the axillary. The axillary is the underarm, okay? So that means we will also put V5 and V6. Okay, they are the precordial electrodes giving you the precordial leads, the electrodes you place on the chest of your patient. Now, what about the other 4? Because I said there's 10 electrodes. Well, if we were to draw up just the stick figure of an individual, you will place one lead, or one electrode I should say, left arm, right arm, left leg, and right leg. Now, you can see I drew 3 the same colour and 1 a different colour. Now, the 3 of the same colour, right arm, left leg, that's important because what you can see is the right leg, which I drew in red, actually does not contribute to the ECG in regards to its view of the heart. It's not a lead, does not give us a view of the heart. It is a ground for the machine. Okay, sort of gets rid of some of that background. So what you can see is 1, 2, 3 electrodes, right arm, left leg, they contribute to the views of the heart. Okay, now this is where they're placed. Now you need to remember that placing them here, so if I were to draw the trunk of this individual, okay, so I'm drawing the trunk of the individual, that placing a lead on a patient's arm is basically the same as placing it at the trunk where that limb connects, okay? So whether it's here or here or here. Now the reason why this is important is because remember we have the heart placed in here roughly. And what we have is the left arm lead is going to have its own little view of the heart. The right arm lead is going to have its own little view of the heart. The left leg lead is going to have its own little view of the heart. But in addition to that, what you'll find is that unlike the electrodes on the chest, these electrodes can speak to each other. Okay? They're called bipolar leads. These are called unipolar leads. Now, that means that the right arm can speak to the left arm. The right arm can speak to the left leg or left foot. And the left arm can speak to the left foot. Okay? So, right arm speaks to left arm. Right arm speaks to left leg. And left arm speaks to left leg. The reason why this is important is because when they talk to each other, they also measure what's going on in regards to the electrical activity of the heart in that particular direction. Okay? So in addition to having a view of the heart from these electrodes, we also have a view of the heart, basically, from this direction, because of this one coming across. We call that limb lead 1. We have a view of the heart from this direction. We call that limb lead 2. And we have one from this direction. So this one's going across like this. We call that limb lead 3. We don't call this lead, because it's a view of the heart, it's a lead now, not an electrode. We don't call this lead right arm. We call it AVR, which stands for augmented vector right arm. Don't stress out about that too much. We don't call this one left arm. We call it augmented vector left arm. And we don't call this left leg. We call it AVF, which is augmented vector foot. So that looks a little bit messy. If I were to just draw this up just here, just a little bit larger, it means that we now have a view of the heart. If I get rid of this very quickly, we have a view of the heart from there, from there, from there. So that's going to be AVL, AVR. This is going to be AVF. We also have a view of the heart from here, which is limb lead 1. A view of the heart from here, which is limb lead 2. And a view of the heart from here, which is limb lead 3. How many views of the heart is that? That's 1, 2, 3, 4, 5, 6 views of the heart from 4 electrodes. So 4 electrodes on the limbs give you 6 views of the heart, plus the 6 views of the heart you get from the precordial give you 12 leads. That's your 12 lead ECG. Please remember, these leads on the chest, they're placed on the chest like this. So they're viewing the heart from that direction. These limb leads are viewing the heart from this direction. So what do we have? We've got a view of the heart from here and a view of the heart from here. We now have a 3D view of what's going on electrically in the heart. Okay? In the next video, I'm going to talk about this in a little bit more detail. So in this video, we're going to have a look at an ECG readout and what that readout means physiologically when we look at the heart. So let's say you've got your patient's lying down, you have the ECG machine. Let's say you have a 12 lead ECG, which means you have the 10 electrodes placed on your patient. If you're unsure where these 10 electrodes go, please watch the ECG placement video. So you've got these 10 electrodes placed on the patient, which is giving you 12 views of the heart. And again, these give you 12 individual views as to what's happening in regards to depolarization and repolarization events. And again, I've done another video looking at depolarization, repolarization. Okay, first thing's this. We're just going to take one example lead. So let's say we have a lead that's placed here. So it's looking at the heart from that direction, right? So you can pretend that it's looking up at the heart. And this set of eyes here, let's say it's lead V5 or lead 2, will give you a view of the heart from around about this angle, okay? It's looking at the heart from this angle, like this, okay? So that means whatever's happening in its direction or whatever's happening away from it electrically, it's going to see. And it spits out some sort of reading. So let's have a quick talk about that. Generally, what you're going to find is that the heart in a healthy individual will begin its contraction starting at this little group of specialized myocardium, a group of specialized heart muscle cells, in a little area here, which we call the sinoatrial node, the SA node. Okay? Now, these group of cells automatically or spontaneously depolarize. Okay? What does that mean? I showed you in the heart muscle cell depolarization, repolarization video that when you have a cell that you have sodium channels and sodium wants to come in, and you have potassium channels and potassium wants to come out. That's sodium, but potassium wants to come out. I told you that some stimulus needs to happen in order to open the sodium channels to let it in. Well, with these sinoatrial nodal cells, there doesn't need to be an external stimulus. They have already some sodium channels open, which means sodium trickles in at all times. Now remember what that means. I told you, so you have to remember. With that graph, when the cell's at rest, it's -90, you have a threshold of -70, and you have a maximum of around about +20, +30. Go back to the video looking at heart muscle repolarization, depolarization. Cells at rest, nothing's happening. Some sodium channels open up and some sodium starts to come in, and it shifts up into the positive until it hits -70. Then it depolarizes. I told you for every other heart muscle cell it needs a stimulus in order for that portion to happen, except the cells of the sinoatrial node. They spontaneously hit depolarization. They spontaneously hit the threshold. Okay? So we have these cells of the sinoatrial node, and they've started to depolarize. Now remember what that means. Depolarization is sodium coming in. Sodium's positive. So you get a wave of depolarization, which is a wave of sodium coming into the cell. And I told you, one heart muscle cell is connected to another, connected to another, connected to another. Which means when sodium comes into one cell, it trickles through. When sodium comes into next, trickles through, it comes into next. That's why it's a wave of depolarization. When these cells of the sinoatrial node depolarize, they depolarize across all the myocardium of the atrium in this direction. Okay? That's the wave of depolarization, meaning all those cells are connected to each other, sodium comes in, goes in that direction, which means, remember, it's going from inside the cell negative to positive, which means you have a wave of positive stuff going in that direction like that. Okay? So, first thing is this. You need to have a look at the lead and where the lead's looking at, and then have a look at the depolarization event and see where that's going to. If you see that the lead is looking at the depolarization event, or the depolarization event is happening in the direction of the lead, what you will find on your ECG readout is every time depolarization happens in the direction of the lead, you will always get a bump up on the lead. Okay? Let's have a look at the cheat sheet that I always tell you about. Okay? So if you were to draw one lead, two leads, three leads, four leads. Draw four leads for me. If depolarization occurs in the direction of the lead, and depolarization, as you can see, is positive stuff coming into the cell. If this happens in the direction of the lead, you will get a bump up on your ECG. Okay? So, under that logic, thinking via that means, if depolarization therefore occurred away from the lead, what do you think the ECG readout would give you? Well, if positive towards gives you up, then positive away should give you a downward deflection. Okay? Okay, let's make it a little bit more difficult. What if, so this is depolarization. What about repolarization? So let's just say all the muscle of the atria have now depolarized, become positive, and then contracts, because I told you that depolarization precedes calcium influx, which then leads to contraction, and then repolarization occurs, meaning the potassium comes out and becomes negative again. Okay? So, if we wanted to reset this and repolarize this heart muscle cell, that means negative stuff moving around. What if repolarization happened in the direction of the lead? So again, use the same logic you've been using. If positive stuff in the direction lead gives a bump up, then negative stuff in the direction lead should give you, so positive and negative opposite. So if positive stuff in the direction lead gives you a bump up, negative stuff in the direction of the lead should give you a bump down. So a deflection in the ECG readout. And again, using the same logic, what if repolarization happened away from the lead? Repolarization away from the lead? Well, it's going to be the opposite. That's the opposite. It's going to be a bump up. Okay? This is the cheat sheet for an ECG. This tells you what's going on. So again, let's look at this either V5 or lead 2. It's viewing the heart from this direction. The sinoatrial node, it's stimulated a depolarization event automatically, spontaneously, it's happened. And it sends a wave of this positive depolarization through the heart in that direction like that. And this is in the direction of the lead overall. You can see that. It's going in the direction of the lead. And if depolarization goes in the direction of the lead, you get a bump up. Okay? All right, next point. Once that's happened, it hits this fibrous tissue. There is a fibrous atrioventricular septum, separates the atrium from the ventricles, and it stops the depolarization wave. So depolarization cannot move through, so it stops it. So once that's happened, no positive stuff's moving through the atria or the ventricles, so you get a flat line. Because there's no positive or negative stuff moving anywhere, the lead won't pick anything up. So you have a flat line. Next thing is this. There is, in actual fact, another group of cells similar to the SA node that sit right there. Now that's the SA node, sinoatrial node, sets the sinus rhythm. This is the AV node, the atrioventricular node, because it sits between the atrium and the ventricles. Okay? So this AV node, once the depolarization wave is spread through, the only place that it can continue through from the atria, it can't get through this fibrous septum, it can only slowly travel through the AV node. Very slowly. It takes 0.1 of a second. So that means that depolarization of the atrium, then contraction, then there's a 0.1 second break while the depolarization wave moves through, and then it continues to propagate. You have a flat line while it's propagating through. So, once that's happened, once the action potential or the depolarization event has moved through, this AV node branches off like this. Okay. And the left branch, now this is called the bundle of His, okay? The bundle of His branches into the left and right Purkinje fibers. But the bundle of His, you'll see the left branch branches off like that. Okay? So that means once this depolarization event has reached the AV node, flat line, it then propagates through these fibers. Now these fibers are really fast. Okay? Very, very fast. And as the depolarization wave spreads down, as it goes down, you can see that it goes down like that. But also down the left bundle and starts to fire up like that. All these branches firing up. So it depolarizes the septum between the left and right ventricle, like that. In that direction, you can see in that direction. That means positive stuff is moving in that direction. So that means, look at the lead. Is this depolarization event going towards the lead or away from the lead overall? Away from the lead, because as it moves down, these ones are going up like that. Okay? So that means what you get is depolarization away from the lead, a deflection, a bump down. Now, this deflection isn't nice and rounded like that because these fibers are very fast, and because it's not a thick tissue, it doesn't last very long, you get a bump down like that. Okay? All right. Once the depolarization event has reached towards the apex, these bundle branches move through and turn into Purkinje fibers that move up like that. And these Purkinje fibers branch off like that. Okay, so that means it's depolarized down, we get a deflection because it's going away from the lead. Then it reaches here. And what you'll find is it starts to depolarize like that. So have a look. Is that overall in the direction of the lead or away? Now you may think, well, this part's in the direction of the lead, so the left ventricle is, but the right ventricle is going away from the lead. So you may go, I don't know what direction this is happening. Well, remember, the left ventricular wall is about 3 times thicker than the right. So what's happening in the left ventricular wall is going to overpower what you read on the ECG to what's happening on the right. So what's happening over here? Predominantly, the depolarization event, which is positive stuff, is going in the direction of the lead. And because the tissue is thick and they're very fast fibers, you get a very high bump up like that. Okay? Now, once it's reached to the what we call towards the base, so remember that's the base of the heart, that's the apex. Once this depolarization event has reached towards the base of the ventricles, the depolarization event moves up like that. So this is the part we're looking at now. You can see it moves up and away. So we have depolarization going away from the lead. It's not a very big bit of tissue and they're fast fibers, so we get another deflection, another bump down. Cool. All right. What's the next part? We have now just depolarized the entire heart. It's all positive now, right? And it's all contracted. So sodium comes in, calcium contracts, sodium comes in, calcium contract. Now what do we need to do? Well, we need to repolarize it. Okay? That's where the potassium leaves the cell to make it negative again inside. Okay? So that means we need to make all this negative again. Now what you need to realize is this. Even though depolarization started here and moved like that, and then went to the AV node and moved like that, and then like that, repolarization does not start where depolarization started. Repolarization starts where depolarization finished, up here, okay? Which means now, repolarization goes in this direction, okay? Repolarization goes in this direction. So, as it goes down, all you need to do is look at the opposite of the dipole. It goes in the opposite direction to dipole. And you saw dipole predominantly go in that direction for that big bump. So repolarization goes in the opposite direction. Okay? And that's making it negative again. So you can see this is happening away from the lead. Right? So we have a repolarization event going away from the lead. What do we get? We get a bump up. And this is your ECG. That's going to reset now. That's going to go back to negative, and then the next cycle can happen. So this is one cardiac cycle. This is one boom, boom, resets, boom, boom, resets, boom, boom, resets, boom, boom. Okay? So this is what we call just a general ECG readout. And you can see it's basically an ECG readout from the V5 or lead 2 cable. So What does that mean overall? It means this. If we look at this first wave represented atrial depolarization. Okay? The next big complex here represented overall ventricular depolarization. Okay? And then the last bump represented ventricular repolarization. And that's what an ECG is measuring. Now you may ask, okay, atrial dipole, ventricular repole, where's atrial repole? It actually happened while ventricular depolarization happened. Because think, dipole, when that did that repoled. And because the ventricle walls are so much thicker, it basically is hidden. The atrial repolarization is hidden behind the ventricular dipole. Now these peaks and troughs have little symbols associated with them, okay? Letters of the alphabet. Atrial dipole, the first wave is called the P wave. The first little dip here is called the Q wave. Then R, then S, then T, which means atrial depolarization is represented by the P wave. Ventricular depolarization is represented by the QRS complex. And the T wave represents ventricular repolarization. And that's all from the view from the V5 or lead 2. Think about if the lead is up here, so the AVR lead. What if the AVR lead was up here, looking at the heart from that direction? What do you think would happen? It's just looking at dipole or repole events, either away or towards. It views the heart from the opposite direction. So what do you think the ECG readout should look like? It should look like the opposite, the inverse, and it does. An AVR readout should look like this. The opposite, okay? I'm going to do another video just probably condensing all this in a very quick summative form, but I hope all this made sense. Hi everybody, Dr. Mike here. In this video, we're going to take a quick look at cardiac output and all the factors that contribute to cardiac output. Now, what is cardiac output? Well, simply put, it is the amount of blood that our heart pumps out every minute. Now, in order to calculate this, there's two major factors that are involved. Well, it sort of makes sense to think if we need to calculate how much blood's pumped out per minute, that we need to know how many times the heart beats or pumps in that minute and how much blood the heart ejects every beat or every contraction. These are the two major factors. Now, first one being the heart rate, and our heart rate on average is around about 70 beats per minute. And the amount of blood that our heart ejects every beat or every contraction, that's termed the stroke volume, and that's around about 70 mils. Again, this is on average. So if you calculate 70 beats per minute times 70 mils, what you get is your cardiac output in a minute, and that ends up being around about 5 liters per minute. That's our cardiac output. Now, obviously these values are the average, and for some individuals like athletes, you'll find that their heart rate is significantly lower, can be around about 50 beats per minute. So in order for them to be able to pump out 5 liters a minute, their stroke volume must be higher, and it is. It can be about 100 mils. And what that means is the heart becomes more efficient, less beats, but with every contraction, more blood is ejected out. Now, if we have a look at all the factors that contribute to these two, heart rate and stroke volume, what you'll find is this. Heart rate being the speed or how many beats per minute, that's influenced by certain hormones in the body and innervation of the body. Predominantly, we're talking about the autonomic nervous system here. We're talking about the rest and digest and the fight or flight system, also known as the parasympathetic and the sympathetic nervous system. They can affect the heart rate. But when we look at the stroke volume, the amount of blood ejected every beat, there are 3 major factors here. One of which is contractility. This is the forceful contraction of the heart. This is about recruiting muscle fibers and the contraction of that heart. Another one is something termed preload. Now, preload has to do with the stretch of the ventricles of the heart just before it contracts, and ejects that blood out. I want you to think about it like this. When we take the heart, if we were to feel the heart, so remember this, when the heart's relaxed, this is called diastole. Under diastole, the heart's relaxed and it starts to fill up with blood, all right? Now, at the end of this relaxation point, it's termed end diastolic volume. End diastolic volume is the amount of blood that has filled the heart at the end of relaxation, all right? So basically, it's going to be the maximum volume of blood in the heart, all right, at any one moment. ESV is end systolic volume. Systole is the contraction of the heart. Therefore, end systolic means right at the end of the contraction. So once the heart is finished contracting, the end systolic volume is the amount of blood left over in the heart after the contraction. So think about it. End diastolic volume, it's at the end of relaxation, the heart is filled up, it's the maximum volume of blood available. Then the heart contracts. When the heart contracts, it's going to eject that blood out. When it ejects that blood out at the end of that forceful contraction, there's going to be some blood left over in the heart. If you take the maximum volume of blood in the heart and you deduct the amount of blood left over in the heart, you end up getting the value of the stroke volume, which is the amount of blood that has been ejected. Now, contractility, preload and afterload affect end diastolic volume and end systolic volume, and therefore affect the stroke volume. Now, I told you about contractility. That's the forceful contraction of the heart. The harder you contract, the more blood you eject out, okay? Therefore, increased stroke volume. Preload, which is what I was getting to, preload is referring to that stretch during end diastolic filling. So the heart under diastole, so it's relaxing, is filling up. As it fills up, it's stretching the walls of the ventricles. Now, at the very end of filling, the ventricles are at its maximum stretch. This is preload. And the reason why this is important is because the more you stretch the walls of the ventricles, the more those ventricles will contract back and eject blood out. This is called the Frank-Starling mechanism. The Frank-Starling mechanism or theory, again, states that the more you stretch the heart, the greater the heart will contract and eject blood out. Therefore, the greater the stretching or greater the filling, the more blood that'll be ejected. So that's what preload is referring to, the stretch on the walls of the ventricles. So if you increase preload, you will increase the amount of blood ejected and therefore increase stroke volume. So increase contractility, increase stroke volume. Increase preload, increase stroke volume. But now we're going to talk about afterload. Now, afterload's different. When we take a look at this heart again, you've filled the heart up. So we've got the end diastolic volume, it's filled up. And we want to eject that blood, let's just say out of the aorta, for example. We need to contract the walls of the ventricles. But there is going to be some resistance experienced in the aorta, in the artery that blood's going to move through. Now, this resistance can be great or can be minimal. If, for example, somebody has some plaque build up in the walls of that artery, you've narrowed that tube and therefore increased the resistance. Think about it. You put your thumb on the end of a hose, you're increasing the resistance. It's harder for that fluid to move through. Same thing's happening here. That is afterload. Afterload is the resistive forces that this blood or the ventricles need to overcome to eject the blood out. Okay, I'll say that again. Afterload is a resistive force that the ventricular walls need to overcome in their contraction to push that blood out. Therefore, if afterload is higher, stroke volume is usually going to be lower. If afterload is higher, the ventricles need to contract harder. If the ventricles contract harder over time, the muscular wall of the heart gets thicker, and that's called hypertrophy. It becomes thicker so it can contract harder to overcome increased afterload. All right, so again, just to quickly run through, cardiac output is heart rate multiplied by the stroke volume, and stroke volume is influenced by contractility, preload, and afterload, which therefore means there are 4 factors that influence the amount of blood that a heart pumps out per minute. That is heart rate, contractility, preload, and afterload. And that is a quick run through of cardiac output. Hi everyone, Dr. Mike here. In this video, we're going to take a look at preload and see how preload influences cardiac output. Remember, cardiac output is the amount of blood our heart pumps out every minute, and it's around about 5 liters every minute. Now, preload, it's one of the factors that influences stroke volume. What's stroke volume? Stroke volume is the amount of blood our heart pumps out every contraction. So you obviously multiply that by how many times our heart beats per minute, and we get our cardiac output. All right, preload, what is it? Well, first thing I need to draw up is a heart. And when we have our heart, we're also going to have some blood vessels, but the only one I'm going to draw up here is going to be the aorta. Now, I want you to think about this. Your heart's going to contract, that's called systole. When it contracts, it ejects blood, and then it relaxes, and that's called diastole, and that's when it fills with blood. We're going to talk right now about diastole. The heart is relaxed, and it begins to fill up with blood. What you'll find is right at the very end of diastole, okay? So it's right at the end of filling, immediately before the heart contracts in systole to eject the blood, you've got the end diastolic volume, that's this right here, and that is going to be the maximum filling of the heart, but it's also the maximum stretching of the walls of the ventricles of the heart, just before contraction. This is actually preload. Preload is the maximum stretch of the walls of the ventricles or the musculature of the ventricles just before they contract to eject the blood. You're probably thinking, why is this important for us to understand cardiac output? And the reason is because the preload, or the maximum stretch of the walls of the ventricles, is proportional to the amount of blood that gets ejected out of the heart. This is called the Frank-Starling mechanism. The Frank-Starling mechanism, and it basically states the more you stretch or fill the heart with blood, the stronger that contraction is going to be, and the more blood gets ejected. That means the higher the preload, so the higher the stretch, the greater the stroke volume. The greater the stroke volume, the greater the cardiac output. So preload is directly proportional to cardiac output. More filling, more contraction, more ejection, okay? Now, things that can affect preload include, well, the major thing that affects preload is venous return. So obviously you're going to have your inferior superior vena cava, that's returning deoxygenated blood from the body back to the heart. And if you have a greater filling, you're going to have a greater preload. If you have a greater preload, you're also going to have a greater stroke volume and a greater cardiac output. But think about this. If the heart rate starts to pump faster, 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 there's less time for diastole. So that's less time for filling, which means a reduced preload and also a reduced cardiac output. So you may think, but wait a minute, an increased heart rate should increase cardiac output, and that's true. But if the heart rate increases too quickly, there's less time for filling and a smaller ejection fraction, so a smaller stroke volume. So it is complex, but all you need to be aware of is, for preload, it is the maximum stretch on the walls of the ventricles immediately before contraction. The greater the stretch, the greater the ejection, the greater the ejection, the greater the cardiac output. That's preload. Hi everybody, Dr. Mike here. In this video, we're going to take a look at afterload and the effect that afterload has on cardiac output. Now, we've spoken about all the other factors involved in cardiac output. We've said that cardiac output is the amount of blood our heart pumps out per minute, and it's determined by how fast our heart beats and how much blood our heart ejects per beat. Now, we spoke about preload in the previous video. That's the maximum stretch on the walls of the ventricles immediately before it contracts to eject the blood out. Afterload is the amount of resistance or force that these ventricular walls need to overcome in order to eject that blood out of the heart. I'll say that again. Preload is the maximum filling of the heart at the end of diastole. It's the maximum filling immediately before contraction, pumping that blood out. Afterload is the force or resistance that these ventricles or muscular walls of the heart need to overcome in their contraction to eject the blood out of the heart. Now you need to think about what could potentially be resistive forces. Well, think about the aorta, for example. The aorta is the major artery exiting the heart to deliver blood to the body. There's going to be resistance in this vessel. Why? Well, because there are certain diameters, certain perimeters, certain boundaries of this aorta that limit the flow coming out. And what you'll find is that some individuals, as they get older, they can have a buildup of plaque or a stenosis or a hardening of the walls of this artery, and it narrows the lumen or the hollow inside, which means you increase the resistance, just like putting your thumb on the end of a hose. You're increasing the resistance and it's harder for the fluid to leave. That means that the muscular wall of the heart needs to contract harder in order to overcome that resistance, okay? Again, afterload is the amount of resistance or force that these ventricular walls need to overcome to pump that blood out. If the resistance is higher, so that means if afterload is higher, it means the ventricular walls need to contract harder to overcome it. Now, the heart's a muscle. When you're in the gym and you start to lift heavier and heavier weights, those muscles have a greater force or resistance they need to overcome. And what do? They grow larger. The heart's exactly the same. The heart needs to grow larger or thicker, gets a thicker muscular wall simply so it can contract harder to overcome the resistive forces in those tubes that the blood needs to exit. Okay? Now this can be a problem because the greater or thicker that wall becomes over time, the more blood or oxygen needs to be delivered to that wall in order to maintain it to be healthy. But if that continues over time to be an increased resistance or increased afterload, so if afterload remains high over time, this wall gets thicker and thicker and thicker in order to overcome it, which means its own oxygen demand becomes higher and it hits a point where it can't supply its own oxygen demand and the heart muscle begins to die or it doesn't work as a pump, and that's heart failure. Okay? So afterload is important for cardiac output because it's the amount of force that these ventricular walls need to overcome to eject that blood out. If the aorta is narrowed for whatever particular reason, it's harder to eject the blood out, so the muscular wall gets thicker. If this is maintained over time, it becomes more, or it has an increased demand for oxygen, and it hits a point where it cannot supply its own demand, and the individual can go into heart failure. So afterload is an important concept to understand when we look at cardiac output. There are some drugs that help with this. Drugs such as beta blockers. Beta blockers help to relax the heart and therefore reduces the workload of that heart. Maybe calcium channel blockers as well, because remember, the more calcium in the muscle cell, the stronger the contraction. So just be mindful of the importance of afterload in cardiac output.